So those of us at Markle have been working for 4 or 5 years on thinking about the problem of how to make information fluid and available to people who need it, when they need it, to manage their own care, to manage a family member's care, to engage with the healthcare system. And so we've had big ideas. And I think now is this perfect moment to drive those ideas into reality with solving problems that people face every day. And for us, it's a very high value to have that problem solving driven by the users themselves, the people who need to get better health care and have better control over their health experiences. So I'm excited that you all are taking this lead, and I think we really see this as one of the first steps forward to shape this process, not from a technology-driven point of view, but from a user-driven point of view. So I'm excited that you're doing this, and of course I'm very pleased that Tom and Susan and everyone have chosen to look closely at the work we've done as part of the picture you're trying to paint. I think one of the jobs I have this morning is a level set, because I know not everyone here lives and breathes IT, and you should be thankful for that. It's a very arcane and complex field, and the policy issues around how to use information technology and how to share information are as arcane as the technology itself. I was in a meeting earlier this week where we spent almost half a day just on the issue of how do minors have access to these records, how do their parents have access to these records, how do you deal with state variation. And as you drill down to any one subtopic within this spectrum, you get into more and more subtle and complex overlaps of technical, ethical, social, policy decisions and debates. So I hope you won't find it daunting but exciting that this is a chance to knit together a lot of elements of our society and its challenges in healthcare. Connecting for Health is a collaborative of about 100 organizations, mostly national groups, medical societies, technology companies, government agencies. Several of you in the room have been involved with helping us think these issues through. We've been working for about 5 years on what is the architecture going to look like as we make health information electronic and widely available. So I'll share with you some of the ideas we've come up with and how they then apply to how we, people, consumers, Americans, patients, can get access to this information. It's probably good as a level set to just separate out some of the elements of what we mean when we talk about information and information technology in healthcare. So at the base level, most of us think about getting the basic information about our health and our health care in a digital form, in an electronic form, so that computers can move it around. The most common way people think about that are electronic medical records or electronic health records in a doctor's office or in another clinical care setting. If the primary information when you or I go to see a doctor or have a test done or get a medication prescribed or filled, if that information isn't digital, everything else gets more difficult for sharing the information. So as a foundational layer, the one question is, how do we get more health information in this country to be electronic in the first place? We won't talk about that much today, but it is a primary underlying challenge that you may want to give some consideration to, particularly in the world you're working in. Just as again, a level set point, only about 15% more or less of American physicians have electronic medical records. You could say 9% use them effectively, 25% might have some version of it, but it's a small number. 80–90% of doctors are not using electronic health records. So the kind of diagrams we'll look at all day today, if they're predicated on having information that is electronic, we do have a primary challenge even at that level. An alternative way to look at it, though, is a lot of the ancillary systems that move our health information around, imaging centers, laboratories, pharmacies, are very highly digital and electronic. So there's an interesting way to think about, as you think about how you want to knit together an electronic disability record, and you tease that apart to where that information that comprises that record is at this moment. A lot of it might be digital, but not necessarily in a doctor's office or in a hospital setting. So there'll be a question for you to think about the acquiring of a primary electronic health information. So if we assume first that we've got a lot of people collecting data digitally, the second tier of problems is how to connect them to each other. And we broadly call that interoperability or connectivity. And that's where we've done a lot of our work, and I'll show you some stories of how we think that might work here in a minute. If we could get everybody to collect data electronically and have a way to share it with each other in an efficient and appropriate and protected way, then the third question people tend to ask is, how does an individual person, a patient, a consumer, a family member, a caregiver, get access to all that information that is scattered across dozens of places in our country? So that's the broad category of personal health records and consumer access.